High liver enzymes do not tell us one story. They tell us the liver, or sometimes the muscles, wants a better investigation. ALT, AST, and GGT are commonly called liver function tests, but that name creates the first misunderstanding. These enzymes mostly act like smoke alarms for cell stress or injury. They do not directly tell us how well the liver is still performing its jobs. And here is the twist that keeps this from being a simple fatty liver video. A brutal leg workout can raise AST and ALT for a week, while someone with advanced metabolic liver disease can occasionally have enzymes that look normal. So today we are building the liver lab decision tree. We will separate exercise, alcohol, metabolic fatty liver, medications, supplements, and bile-duct patterns, and identify the combinations that need urgent care rather than an online liver cleanse. ALT, AST, and GGT are clues. They are not verdicts. ALT stands for alanine aminotransferase. It is found most heavily inside liver cells, so it is generally more liver-focused than AST. ALT can rise with metabolic dysfunction-associated steatotic liver disease, viral hepatitis, medication or supplement injury, autoimmune disease, alcohol exposure, and reduced blood flow to the liver. But ALT alone cannot tell us which one caused it. AST stands for aspartate aminotransferase. The liver contains AST, but so do skeletal muscle, heart muscle, brain tissue, kidneys, and red blood cells. That means AST may be reporting on the liver, or yesterday's deadlifts. GGT stands for gamma-glutamyl transferase. It is associated mainly with the liver and bile ducts and can help determine whether an elevated alkaline phosphatase is coming from the hepatobiliary system. But GGT is sensitive rather than specific. Alcohol, metabolic dysfunction, medications, and biliary disease can all raise it. GGT is a clue, not a confession. Now the first question. How abnormal are the results? A value barely above the laboratory limit is a different situation from an ALT or AST in the hundreds or thousands. Mild abnormalities may still matter when they persist, while very high or rapidly rising levels can signal acute hepatitis, medication toxicity, poor blood flow, or another serious injury. The size of the enzyme rise does not equal the percentage of permanent liver damage. A dramatic acute injury may recover, while years of quieter disease can build fibrosis without spectacular numbers. Next, look at the pattern. When ALT and AST are much more elevated than alkaline phosphatase, clinicians call it a hepatocellular pattern. Possible causes include MASLD, alcohol-associated disease, viral or autoimmune hepatitis, medication or supplement injury, and sometimes muscle damage. When alkaline phosphatase is the dominant abnormality, especially with elevated GGT or bilirubin, the pattern is more cholestatic. That raises questions about gallstones, bile duct obstruction, biliary disease, medication injury, or other structural problems. When both groups are meaningfully elevated, it is a mixed pattern. The surrounding labs and timeline determine where the investigation goes next. Now the exercise branch, one of the easiest causes to miss. In a controlled study, 1 hour of intensive weightlifting raised AST and ALT in healthy men, and both remained elevated for at least 7 days. Creatine kinase, myoglobin, and other muscle damage markers rose as well, while bilirubin, GGT, and alkaline phosphatase did not follow the same pattern. Questions that strengthen a muscle explanation include recent heavy resistance training, unfamiliar eccentric exercise, extreme soreness, weakness, swelling, elevated CK, and AST rising more than ALT. For a stable person without concerning symptoms, a clinician may repeat the panel after approximately 7 days without strenuous training and add CK. But exercise is an explanation to test, not an excuse to ignore abnormal bilirubin, GGT, alkaline phosphatase, INR, symptoms, or persistent elevations. Your liver panel may be reporting leg day. It still deserves a follow-up interview. Now alcohol. An AST-to-ALT ratio above 2 can raise suspicion for alcohol-associated liver disease in the right clinical setting. But the ratio is not a breathalyzer. Muscle injury can raise AST. Advanced cirrhosis from other causes can also produce AST-predominant results. And people with heavy alcohol exposure do not always present with the classic ratio. GGT may rise with alcohol, but it can also rise with MASLD, medications, metabolic syndrome, and biliary disease. A normal GGT does not provide an alcohol-free certificate of authenticity. The important questions are actual standard drinks, oversized home pours, weekend binges, recent changes in intake, bilirubin, INR, platelet trends, and whether the numbers improve during clinician-guided abstinence. Alcohol and metabolic fatty liver can also coexist. The liver does not require us to choose one villain when two stressors are available. Now MASLD, the condition previously called non-alcoholic fatty liver disease. MASLD is strongly connected to insulin resistance, abdominal obesity, type 2 diabetes, high triglycerides, hypertension, and sleep apnea. A common early pattern is ALT higher than AST, sometimes with elevated GGT. But normal ALT and AST do not rule it out. People can have liver fat, inflammation, or even significant fibrosis while routine enzymes remain normal. That is why metabolic context matters: waist circumference, A1C, triglycerides, blood pressure, diabetes, previous imaging, family history, and platelet trend. FIB4 is a common first-line fibrosis risk score using age, AST, ALT, and platelets. A result below about 1.3 often suggests lower risk in the appropriate primary care population, while 1.3 or higher may lead to elastography or another secondary test. FIB4 is not a home cirrhosis detector. Age, acute illness, and temporary exercise-related AST changes can distort it. Ultrasound may identify moderate liver fat, gallstones, bile-duct dilation, or structural changes. FibroScan or other elastography adds information about liver stiffness, but no single scan replaces the whole clinical picture. Now medications, especially acetaminophen. Acetaminophen appears in hundreds of prescription and over-the-counter products. Someone may take Tylenol, a nighttime product, cold medicine, and prescription pain medication without realizing several contain the same drug. Excess acetaminophen can cause acute liver failure, and early symptoms may be mild or absent. Suspected overdose is a poison control or emergency care problem, not something to monitor with milk thistle and optimism. Do not abruptly stop an important prescription because ALT increased. Make a complete list of prescriptions, pain relievers, cold products, recent antibiotics, antifungals, seizure drugs, cholesterol drugs, hormones, and anything borrowed from someone else. Then add every supplement. Herbal and dietary supplements can cause hepatocellular, cholestatic, or mixed liver injury. Higher concern categories have included multi-ingredient weight loss products, bodybuilding formulas, anabolic steroid products, concentrated green tea extract, kava, red yeast rice, and rare reactions to several popular botanicals. This does not mean every person taking turmeric or ashwagandha will injure the liver. It means natural does not make a product invisible to liver cells, and multi-ingredient blends can make the responsible ingredient almost impossible to identify. Do not respond to unexplained liver enzymes by adding a liver detox supplement. The investigation needs fewer variables, not a botanical group project. Now look beyond ALT and AST. Bilirubin rising with jaundice, dark urine, or pale stools increases concern about impaired processing, excretion, or obstruction. Alkaline phosphatase plus GGT points more strongly toward the liver or bile ducts, while alkaline phosphatase with normal GGT makes bone or another source more plausible. Platelets matter because a falling count can accompany portal hypertension in chronic liver disease and is part of FIB4. Albumin and INR provide information about the liver's synthetic work, although both can be affected by other conditions. A rising INR in someone who is not taking warfarin is far more concerning than one mildly elevated ALT after squats. Here's the practical decision tree. First, check urgency: jaundice, confusion, severe sleepiness, bleeding, persistent vomiting, severe right upper abdominal pain, abdominal swelling, suspected acetaminophen overdose, or very high and rapidly rising enzymes require prompt evaluation. Second, confirm the abnormality and identify the pattern using ALT, AST, alkaline phosphatase, bilirubin, and GGT. Third, ask about muscle, recent hard training, soreness, weakness, swelling, dark urine, and CK. Fourth, review alcohol honestly, not morally, mathematically. Fifth, assess metabolic risk and consider FIB-4, ultrasound, or elastography when appropriate. Sixth, build a medication and supplement timeline. What started, stopped, changed dose, or changed formula during the previous months. Seventh, use the surrounding tests: bilirubin, albumin, INR, platelets, CK, hepatitis testing, iron studies, glucose, A1C, and lipids. Finally, repeat under controlled conditions only when the situation is stable and a clinician agrees. That may mean normal hydration, no hard training for about a week, and a meaningful alcohol-free period when alcohol is a suspected contributor. Do not casually wait when bilirubin or INR is abnormal, symptoms are present, enzymes are markedly elevated, or a dangerous exposure fits the timeline. If this helped turn a frightening red lab result into a rational investigation, tap like, subscribe to Longevity Compass, and check the description for our Amazon KDP book and tools for tracking medications, supplements, metabolic risk, and laboratory trends. Because ALT, AST, and GGT are smoke alarms. The safest response is neither panic nor dismissal. It is finding out what produced the smoke.